Okay, so hi everyone. Today we're going to be talking about middle cerebral artery stroke syndromes. So before we go into the topic proper, just a short recap on the circle of Willis. So we have our two vertebral arteries. They join to form the basilar artery. The basilar artery ends up giving lots of branches. That is your pontine branches, your ICA, superior cerebral artery, and finally the terminal branch, which is the posterior cerebral artery. And the posterior cerebral artery in turn is connected to the internal carotid artery via the PCOM or the posterior communicating artery, and the internal carotid artery then gives the middle cerebral artery. So this is the middle cerebral artery, and it also gives the anterior cerebral artery, and the anterior cerebral arteries are connected to each other via the ACOM, that is the anterior communicating artery. So today we'll discuss in detail about the middle cerebral artery. Okay, now coming to the anatomy of the middle cerebral artery. So here you can see this is the internal carotid artery. It splits into the anterior cerebral artery and the middle cerebral artery. So the middle cerebral artery has two segments. So one is the M1 segment, that is a proximal segment. So this is what you're seeing here is the M1 segment. And then when it divides into the two main cortical branches, that is known as the M2 segment or the M2 branches. So in the M1 segment, we have one main branch, that is the penetrating arteries or the lenticulostriate artery. So you can see these bunch of branches over here. These are the deep penetrating arteries or the lenticulostriate arteries. These end up going and supplying the posterior limb of the internal capsule, the putamen, the outer globus pallidus, a major part of the caudate nucleus. Okay. Then what happens is the middle cerebral artery, it travels in the sylvian fissure and divides into the superior division and the inferior division. So this is the superior division and this is the inferior division. So this is the M2 segment, or these are the two M2 branches of the middle cerebral artery. Okay. So the MCA superior division supplies the frontal lobe and the superior part of the parietal lobe, whereas the inferior division supplies the inferior part of the parietal lobe and the superior part of the temporal lobe. Okay, so this is the MCA anatomy of the M1 segment. It gives the lenticulostriate branches, and then we have the two M2 branches, that is the superior division and the inferior division. Okay, now coming to the different parts which is supplied by the middle cerebral artery. So we have the M1 segment, as we discussed earlier. It's a proximal MCA. It gives rise initially to the lenticulostriate arteries that we discussed earlier, which supplies the putamen, the posterior limb of the internal capsule, the adjacent corona radiata, the outer globus pallidus, and a significant part of the caudate nucleus. Then what happens is the MCA bifurcates, okay, it travels in the sylvian fissure and bifurcates into the M2 branches or the cortical branches, that is the superior and inferior divisions. The superior division is going to supply the frontal cortex and the superior parietal cortex, and the inferior division is going to supply the inferior parietal cortex and the superior part of the temporal cortex. Okay, so as you can note, the MCA is supplying a significant part of the lateral surface of the cerebral hemisphere. So this entire part is supplied by middle cerebral artery, except for the frontal pole. The frontal pole and the superomedial margin of the frontal and parietal lobes, this is supplied by the anterior cerebral artery. And then the inferior part of the temporal lobe and the occipital cortex, this is supplied by your posterior cerebral artery. A point of note over here we have the occipital pole. Okay, so always remember that the occipital pole, which actually represents the macular vision, has dual blood supply. It's supplied by both the posterior cerebral artery as well as the middle cerebral artery. This is the reason why we get macular sparing in occipital lobe infarcts. The reason why we get macular sparing in occipital infarcts is because of the dual blood supply. Both posterior cerebral artery and the middle cerebral artery supplies the occipital pole. So that's an important applied anatomy. Alright. So as we discussed earlier, the MCA is going to supply a significant part of the lateral surface of the cerebral hemisphere, except the frontal pole and the superomedial strip of the frontal and parietal lobe supplied by the anterior cerebral artery, and the lower temporal lobe and the occipital lobe. This is supplied by the posterior cerebral artery. Okay, now since we are acquainted with the anatomy, we'll go into the MCA occlusion proper. So the most common cause of MCA occlusion is going to be embolic stroke. The most common cause is embolism. However, atherosclerosis is less common. Compared to embolism, atherosclerosis is going to be less common, and this is because of the presence of collateral formation via the leptomeningeal vessels. And remember, atherosclerosis or intracranial atherosclerosis is more common in Asian patients. Okay, overall, if you take embolism, MCA occlusion is most common due to embolism, and second most common is going to be atherosclerosis, and usually atherosclerosis is more common in the Asian population. Okay, now coming to the different stroke syndromes at different points of occlusion. So again, we'll just simplify the diagram we saw earlier. So we have the M1 segment. It's going to give the lenticulostriate branches, and then it splits at the M2 segment to the two M2 branches, that is the superior division and the inferior division. So this is the M1 segment and this is the M2 segment. Okay, now let's say we have an occlusion over here, that is a proximal MCA occlusion. So here what's going to happen, your lenticular branches are going to get involved, your superior division is going to get involved, and the inferior division also is going to get involved. So what are the different clinical features? So you're going to get contralateral hemiplegia. So why so? So as you know, the superior division is going to supply the frontal lobe, superior parietal lobe, and the inferior division is going to supply the temporal lobe and the inferior parietal lobe. So why you're going to get contralateral hemiplegia is, in the frontal lobe, as you know, that you have the motor cortex. You have the motor cortex. So this is involved, so you're going to have hemiplegia. And next, your lenticular branches are also involved over here. This, as you know, is going to supply the posterior limb of the internal capsule. So because of this also, overall if you take, you're going to get contralateral hemiplegia because of internal capsular involvement, and also the motor cortex is infarcted. Then contralateral hemisensory loss. So why do we get this? This is because of involvement of the parietal lobe. As you know, parietal lobe, you have your sensory cortex. You have your sensory cortex. So because of that, you're going to get contralateral hemianesthesia or hemisensory loss involving all sensory modalities. Next, contralateral homonymous hemianopia. So this occurs because of infarction of the optic radiation. So since the optic radiation is got infarcted, you're going to get contralateral homonymous hemianopia. And gaze preference to the ipsilateral side. So what happens is, as you know, the frontal lobe, you're going to have your frontal visual eye fields. You're going to have your frontal visual eye field. So because this is involved, there's going to be gaze preference to the ipsilateral side or the side of the infarction. Next, coming to the cortical involvement, other higher cortical functions, what you're going to see is, in case the dominant hemisphere is involved, you're going to get global aphasia. You're going to get global aphasia. Why? Because in the frontal lobe, you have the Broca's area. You have the Broca's area, and the temporal lobe, you're having the Wernicke's area. So as you know, the Wernicke's area is very important for comprehension of speech, whereas Broca's area is very important for speech output. Okay, for fluency of speech. So since both are going to get involved, patients are going to have global aphasia in dominant lesions. And remember, dominant lesions, usually it's the left side, not always the left side, but most of the time the dominant hemisphere is in the left side. Okay, what is the other dominant hemisphere issue is Gerberman syndrome. So when you're going to have a dominant parietal lobe involvement, you're going to have Gerberman syndrome. This is a very, very important MCQ. So the four cardinal manifestations of Gerberman syndrome is acalculia. So patient will not be able to do simple mathematical problems. Alexia, patient will have difficulty in reading. Finger agnosia, patient will not be able to identify his own fingers, which is index finger, which is middle finger, and also not only his fingers, the others fingers also. And patient will have right to left confusion. So these are four cardinal manifestations of Gerberman syndrome. It's a very, very important MCQ. Don't forget this point. So dominant parietal lobe involvement is always Gerberman syndrome. So these are the issues with dominant hemisphere. So dominant hemisphere, you're going to get global aphasia and Gerberman syndrome. So non-dominant hemisphere infarctions, what do you get? You get anosognosia, which is nothing that patients doesn't have insight into his problems. Patients not aware or not able to perceive his neurological deficit. Then your apraxia, that is difficulty in carrying out or executing skilled activities. So constructional apraxia, dressing apraxia, and then patient will also have hemi-neglect. So these are the features of non-dominant infarctions. Okay, now let's move a little more distally. Now coming to the MCA superior division, again we'll draw a simplified diagram. So we have a lenticular branches, the M2 branches, that is the superior segment and the inferior segment. Here frontal, parietal, superior division is going to supply frontal and parietal. Here also to some degree the inferior part of the parietal lobe and the superior part of the temporal lobe. Okay, now let's look at the clinical features. So here you're going to have Broca's aphasia. In case it's going to be dominant, always remember speech abnormalities are always due to dominant hemisphere infarctions. So MCA superior division, dominant hemisphere involvement, you're going to get Broca's aphasia. Why so? Because here in the frontal lobe, as you know, that you're going to have Broca's area. You're going to have Broca's area, and Broca's area is very important for fluency of speech. So patient is going to have a non-fluent aphasia. Patient will be able to comprehend what you're saying, but will not have an adequate speech output, or the speech will not be fluent. Okay, so Broca's aphasia. Contralateral hemisensory loss. Why so? Because superior division supplies also the parietal lobe. So here the sensory cortex is going to get involved. So you're going to have contralateral hemisensory loss or hemianesthesia. Contralateral hemiplegia. But the face and the upper limb is going to be more involved than the lower limb. So why is this so? Because the reason for contralateral hemiplegia and in superior division involvement is because your motor cortex in the frontal lobe is going to get infarcted. However, your internal capsule is spared. Since your lenticostriate branches are present more proximally, that's going to be spared. So if you have a look at the motor homunculus, so if you look at this area, the lower limbs of the legs are represented more medially. Okay, they are represented more medially, whereas your upper limb and face are present in this area, the more on the lateral surface. As you know, this part is supplied by your middle cerebral artery, whereas this medial portion over here is supplied by your anterior cerebral artery. So that is why when you have superior division infarction, so as you know, this is a Sylvian fissure, this is superior division, you have an occlusion here. So here you're going to have predominant weakness involving the face and the upper limb, whereas your lower limbs will be relatively spared, because that cortical representation is supplied by the anterior cerebral artery. And also, since your internal capsule is preserved, you won't have lower limb involvement. So you're going to have a contralateral hemiplegia with predominant face and upper limb involvement. Okay. Now coming to the inferior division occlusion. So again, we'll draw a diagram. So we have the M1 segment, lenticostriate branches, superior division, inferior division. That is your M2 branches. So as you know, this is going to supply frontal, parietal. This is going to supply inferior parietal lobe and the temporal lobe. So here you're going to have vernix aphasia. Okay, so you're going to have vernix aphasia. Why so? Because in the temporal lobe, you're going to have your vernix area. And as you know, vernix area is very important for comprehension of speech. So again, only in dominant hemisphere involvement, not in non-dominant hemisphere. So at vernix aphasia, patient will not be able to comprehend, but will be fluently blabbering something. They'll have jargon speech, neologisms. The speech won't make any sense at all, because their comprehension is impaired because of temporal lobe involvement, vernix area. There is no weakness over here. Very, very important MCQ. There is no weakness in inferior division occlusion because there are no motor fibers here. So you're having occlusion here, your internal capsule is spared, and your motor cortex in the frontal lobe also is spared. So there are no motor fibers running over here. So there will be no weakness. Next, you're going to have contralateral homonymous superior quadrantanopia. So why you have this is because the inferior optic radiation runs through the temporal lobe. And as you know, when the inferior optic radiation is involved, you're going to have a superior quadrantanopia. Okay, that's important. And rarely the patient can have an agitated confusion state. This is because of temporal lobe involvement. However, it's pretty rare. Okay, now coming to lacunar stroke. So this is also very important. So again, we'll draw a small diagram, simplified diagram. This is the M1 segment, lenticostriate branches, splitting into the M2 branches, that is superior and inferior. So now we are having a issue over here. Okay, so now our issue is over here in the lenticostriate branches. So what is the main pathology over here is, as you know, in MC occlusion, the main cause is going to be embolic stroke. But here, in the lenticostriate branches, the main pathology is lipohyalinosis. It's going to be lipohyalinosis. Okay. So, as you know that the lenticostriate branches supplies the internal capsule, the posterior limb of the internal capsule, the caudate, the putamen, and the globus pallidus. So, you're going to have a contralateral pure motor stroke. So why? Because your cortical functions are intact. So your cortical branches are not involved. So all your aphasia, apraxia, anosognosia, nothing is going to be present. Only you're going to have motor findings. That is a contralateral pure motor stroke. Another internal capsular lesion can cause clumsy hand and dysarthria lacunar syndrome. Okay, and rarely you can have Parkinson. It's not very commonly seen, even though the lenticostriate branches supplies a significant part of the basal ganglia. Parkinsonism and hemiplegismus is rarely seen when the globus pallidus and the putamen is involved. Okay, so this is about MCA stroke syndromes. I think I've covered most of the important points. Thank you.